यस, ये लाइव भी हो गया और मैंने होस्ट बना दिया आपको। ठीक है, मैं लैब कर रहा हूँ। ठीक है। हेलो। नाउ सेशन हैज बीन स्टार्टेड।
It may appear normal also, and it may appear as low pressure voiding also. So best thing would be if there is terminal overactivity and patient is not able to hold and start voiding, we should empty the bladder again and repeat the study. In this graph, abdominal and vesical pressure, they were equated and the total pressure was zero initially. Then, at the capacity of around 300 ml, there was urgency and strong desire to pass urine. There was overactivity and leak followed. In this, the increased EMG activity in the last line. In this, that is an attempt by the patient to suppress this involuntary contraction. Second thing which we see in filling cystometry is compliance. Mathematical formula is this. Either it can be normal, multiple numbers they have been suggested for compliance, but usually we would take 30 to 40 ml per centimeter of water as normal, and more than that, studies have shown that it can affect upper tract. So it is usually calculated between 2 points compliance at the start of filling and at systometric capacity. That means the whole graph that needs to be studied for assessing compliance. Compliance should not be calculated at the time of detrusor contraction. This is what a typical graph with pure compliance would appear like, in which detrusor pressure is constantly rising and the abdominal pressure is not affected during this stage. Now, this is the difference I was talking about. First is the normal vesical pressure. In second, the vesical pressure is constantly rising, so probably poor compliance may be there. Now, once we stop filling, this graph comes down to almost near the baseline. So that is artifactually poor compliance. That means actually the compliance is not that bad, but probably it was associated with higher fill rate. If it doesn't come down and it constantly keeps on rising the pressures, that means it is true poor compliance. So this is what we need to actively find out during a study. Another feature which we study is bladder capacity. Cystometric capacity, it depends on the fill rate and a lot of factors. Filling should be stopped when there is some pain or a large volume has been infused. without any significant sensations. Practically, we would do it around 500, 600 or 700 ml. Maximum systematic capacity was around 500 with us again with a strong desire to pass urine. In this graph, it shows a small systomatic capacity over sensitive bladder. Why? Because we have asked for initially there is Valsalva. Early sensations are there at just 56 cc. Early desire to pass urine at 43 ml and around a very strong desire to pass urine around 100 ml. The EMG activity increases to suppress this urgency and the maximum capacity was around 270 ml. So this is the small systometric capacity. We have to correlate this with the functional bladder capacity which we have already seen in the voiding diagram. If it doesn't match, if at some point patient is able to hold more urine, we are supposed to repeat the study. Another factor which we see in filling systometry is the urethral function during filling phase. Urethra, it cannot be overactive. It's the normal, that means it maintains continence with increased intra-abdominal pressure, or sometimes it's maybe overcome by strong diffuser overactivity and lead to incontinence, but still it may be normal. And incompetent urethral function. That means it allows you leakage in absence of any diffuser contraction. Another factor which we see during filling is EMG activity. So, what are the indications? All urogenic patients, with or without residual urine or without symptoms, they should have EMG electrodes in place. All non-neurogenic patients with obstructed flow and again no anatomic obstruction. That means we have documented that patient is not having obstruction through multiple tests and sometimes after cystoscopy. Then we need to assess urodynamically what is going on. During this, we need to keep an eye on filling, what is happening to EMG activity, and what happens on provocation. While provocation, we can also ask the patient to contract the perineum. And this again gives us very important information. Suppose later on, we are going to ask him or her to do Kegels exercises. If during this study, if patient is not able to contract the perineum or pelvic floor, and we are not able to document the movement on EMG graph, we can take this opportunity to teach them that this is the particular area or muscle which you should try and contract. Tell them to relax other parts, high, lower abdomen, back, and just focus and concentrate on the part. If they're doing it correctly, they'll be able to appreciate it on the graph. This trace shows the EMG response to cuff. Increased signals with cuff or valsalva. During normal micturition, EMG activity disappears completely for a few seconds before diffuser contraction. This is coordinated, especially from pontine micturition center. In this graph, it shows that there is graph tracing goes up in abdominal and vesical traces, and the EMG activity increases. Again, this is suppressing diffuser contraction with the pelvic floor contraction. This is something which we may see in especially spinal cord injury patients, in which there is exaggerated recruitment or guarding reflex. What happens when there is bladder filling is there? Then in response to that filling, the EMG activity gradually increases, and it keeps on increasing because of recruitment. And this we can appreciate in spinal cord injury patients, and this is the normal. This is the expected pathological response. This is a rare, uncommon case in which a patient has been given interstitial device. What happens throughout the study? There is the activity of EMG. It is there. Once the device is switched off, the EMG activity goes down, As soon as the device is again turned on, it reaches to same level. So just to show the effect of interstitial device on EMG activity, I have placed this now. Now, another factor which we consider is abdominal leak point pressure. It is defined as intravesical pressure at which the urine leakage occurs due to increased abdominal pressure, again in absence of a detrusor contraction. It is very important. We have to document that during this leakage there was no detrusor contraction. What is the utility? It is used to measure the ability of bladder neck and the urethral sphincter mechanism to resist the increased intra-abdominal pressure. It has been generated by two ways, either through Valsalva or cuff leak point pressure. Cuff leak point pressure, it is more clinically relevant, it is rapid, and it gives a stronger curve. Another point is detrusor leak point pressure. It is defined as lowest detrusor pressure at which urine leakage occurs, again in absence of either a detrusor contraction or increased abdominal pressure, both. So, what is the utility? It measures the capacity of the bladder neck and urethral sphincter mechanism to resist the increased pressure. A cutoff has been given of around 40 centimeters of water, but it is not absolute. What are the factors affecting this? Neurogenic bladders, pelvic organ prolapse. We can reposition the prolapse with a vaginal bag and then study. Patient positioning may affect this and the bladder fill volume. It is most useful in patients with lower motor neuron disease, in which like spina bifida, spinal cord tumors after abdominoperineal dissections, radical hysterectomies. These are the cases in which detrusor leak point pressure might be helpful. So higher the DLPP, the more likely is that the upper tract damage may occur. And why the cutoff of 40? The cutoff 40 was there because study showed that there was 85% chance that the urine would reflux in upper tracts if this limit was crossed. So a cutoff of 40 centimeter of water was given. But practically, the upper tract may be damaged even as low as values of 20 centimeters. So more important is correlating it with the anatomical findings. If the upper tract is getting damaged, then probably the 20 value of 20 is important, and we should modify our treatment based on that. This was a 49-year-old lady with a neurogenic bladder. Persistent incontinence was a complaint after ileovasectomy. She used to leak around change three diapers in a day. The incontinence was either because of bladder neck weakness or detrusor overactivity. Then intrinsic sphincter deficiency was also to be ruled out. A series of cuff were asked for at around 130 ml fill volume. The Valsalva leak point pressure was around 44 and a cuff leak point pressure was around 100 centimeters of water. In this first sensation occurred very early. The compliance was normal. The capacity was small, around 172. There was no overactivity documented throughout the study. Now, the part of graph which is we have magnified, it shows there is leak of urine at two occasions. Now, this leak, it was documented through contrast emptying in fluoroscopy images. Bladder neck was open throughout. So this was diagnosed as secondary stress incontinence, secondary to intrinsic sphincter deficiency. That is weak external sphincter. So now this patient we can safely use either injection therapy or autologous slings or bladder neck closure options. Reporting the sensations. These sensations. This sensations are again subjective, so we have to explain and then carefully examine throughout. They may be reduced, normal, or increased, like in interstitial cystitis or associated with infection. Normal values they vary from first sensation around 200 ml, first desire to void around 300 ml, and a strong desire to void around 450 ml should be there. So, what to look in the traces? We have discussed few things. We should look for baseline stability throughout the study, basic contractions, whether they are there, compliance, and leak point pressure, which we have discussed. Now, this is the image of the bladder prolapse. In this case, the bladder capacity would be the part of the prolapsed bladder plus the actual orthotopic volume. Again, in second image, the actual bladder volume would be the bladder volume plus the volume of right side the dilated system. In these cases, video fluoroscopy is very helpful. In this graph, the image shows that bladder neck is closed, sphincter is not opening, and this corroborates with the finding in the graph. The EMG activity is going up with the reducer pressure. So this indicates external sphincter dyssynergia. So while we have to prepare report of filling cystometry, what points we should include? Capacity, compliance, sensations, contractions if they are there, and the continence status. Whether it was associated with stress or urgent incontinence. Now, ICS terminologies. Since 2002, few things they have remained same. They are same for theoretical importance. But after 2017, few new terms have come up, of which very important points are there has been no change in urethral pressure measurements. It has remained same, and very significantly, artifacts they have been added to this definition. Now we know what is a dead signal. We actually have to mention it on paper. Why are these important? Because once we know these definitions, we can actually mark them on the graph we are sending out. Then pressure drift, a sudden change in pressure, which is not explained physiologically. Then core pressure transmission, that is when cuff or effort pressure peak signals are there, and the changes are equal in intravesical and abdominal pressure. Expelled catheter, that event is to be documented. Then catheter flush. Usually we would pause the study if we need to flush at any point of time. If it is there on graph, we have to mention. Then tube knock or pump vibration. Sometimes it happens that the tube is in contact with the pump and there are regular vibrations which are oscillations which are documented on graph. That we need to tell, because the person who is reading doesn't know all these intricacies during the study. That's it.
Thank you, Dr. Dhawan. I think that we will have enough time to discuss all these filling cystometry by doing our live demonstration cases and during the panel discussion also. We are running quite short of time because it's almost an hour late that we are running. So next speaker is none other than our chairman of Indian Institute of Urology, Dr. Sujata Patwardhan. She will speak, give a brief presentation on pressure voiding cystometry, and then we will have small two presentations, brief presentation from our guest speaker, Dr. Shirish Yande, who has come from Pune, and he will give us some presentations. So after that, we might have our lunch, and then we can start the live demonstration. So we'll just let you know exactly. So I invite Dr. Sujata for her presentation. Thank you.
So as usual, I'm going to keep my presentation very steady, and there are only few learning objectives which I want you to learn from what I'm going to speak. And once, yeah. So, very few things I want you to take back from what I'm going to tell you. And this will not involve any complicated terminologies. And I have a firm belief that if you read Campbell 4 times, you will be able to pass urology and you'll be really able to do a good scientific and ethical practice. So, for the bladder, for a bladder to function, we need the detrusor to contract. So it's as simple as that. And we need to measure the bladder outlet resistance. So there are two things we need to measure. Does the detrusor contract and is there outlet resistance? Now the detrusor contraction may have various types of problems. That the force of contraction may not be adequate. It may be a too short a contraction, or it may be totally impaired, or it may be an contractile detrusor. So, need to diagnose only 3 things for the detrusor. For the outlet, we want to know whether the resistance is producing too much of resistance or it is producing no resistance. Or there may be a problem that both the things may be, the patient may be having a combination of both. So as long as you understand this, and this is what we want to learn from the voiding pattern, that's more than adequate. Is the detrusor contracting? Is there outlet resistance? Or are both of the things happening simultaneously? Now we know what is normal micturition. Our higher centers, the suprapontine centers, first tell us whether the place is adequate for us to, or safe enough or comfortable enough to pass urine. Then we know that there are these pontine and sacral micturition centers which coordinate. The first thing which happens is relaxation of the external sphincter. Immediately, it is preceding the contraction of the detrusor followed by flow of urine. This is the very simple things which we want to know. And this is a diagram from Campbell, that which you can easily see that in the first part, when the bladder is coming to capacity, the external sphincter is contracted and it is closing the outlet. The moment the bladder starts contracting, it has relaxed, it is allowing the outlet to open, and immediately when the bladder is finished emptying, the sphincter contracts. But this is all you need to know. If you understand this much, then we can understand the rest of the things. I'll come to this slide later on. Now, what are the possible scenarios which can happen? What is the normal detrusor contraction and what is normal voiding? I told you that the voiding is continuous, it is complete, and in the absence of any obstruction. So the detrusor is contracting completely, it is emptying the voiding completely, and there is no obstruction. This is normal voiding. Then what is DU? DU is a term which is the most important part is detrusor underactivity. On this, all the problems start in urodynamics, because this has many implications. We are not able to understand this properly, completely, and this is the only scenario which we face in practice, which can cause us problems. So this I will also explain to some extent, and Dr. Yandre sir has a very good presentation, and he will also explain. So this is one thing which we are in the gray zone, and we do not understand very completely. And what is the other scenario is it's taking a prolonged time for emptying, or there is failure or completely emptying. And the last scenario is very easy to understand. There is no contraction, detrusor is not functioning, or reflexia. And it is now named as neurogenic or contractile detrusor. It's not called reflexia anymore. So you understood? One is normal voiding, one is the gray zone, which we don't know, and we will learn more as we go ahead, is DU. And the third part is very easy. Detrusor is not acting, it is not contracting, and that is where we call it neurogenic or contractile detrusor. Now, detrusor underactivity or DU this is this for us to understand more and to understand in a better way. Various people in this field uh, have this. It depends on two factors. It depends on the detrusor contraction. It depends on the outlet resistance, and that is why this they have defined a contractility index. Now, contractility index, I will try and explain to you in the next few slides. Just before that, we have to what is the simple most thing where we can diagnose obstruction is a low UFR and a low UFR and a large post-void residue. This in the presence of a high PDET is obstruction. So three things will diagnose obstruction, and which is very easy for us to diagnose. I'll take you in our next in the last session we have also graphs to explain to you. So a high PDET, a low UFR, and a large post-void residue. These are mostly, this is the broad definition of obstruction. So the minimum volume which we need to depict this linear relation between the PDET and the voided volume should be 150 ml. Now, it is not rational to get a proper value of the Qmax, or the PDET at Qmax if the patient voids only 50 ml or if he voids 1000 ml. So these two things we should keep in mind. So you can make very easily a diagnosis of obstruction on the three things I told you. But what are the caveats to it? The caveats is when the patient voids a very less amount of urine or he voids a very large amount of urine. And as we many times know that most of our patients, though we want them to void 150 ml, they do not void 150 ml, and therefore we have designed nomograms. And one of the formula which is easy to apply in this subgroup of patients is Qmax divided by the square root of voided volume. So this is one formula you should know where you will get the Qmax. Now this is another test which is sometimes asked in exams but not done, is Bethnicol sensitivity test. Now, Bethnicol hydrochloride can be injected in a dose of 2.5 milligrams subcutaneously. And the theory behind this is if the patient has a neurogenic cause for detrusor dysfunction, if he has something in his neurogenic system which is accounting for his detrusor dysfunction, the bladder will overreact. And if it is a myogenic cause, that is the detrusor itself has become fibrosed or contractile because of disease or prolonged obstruction or whatever be the reason, then it will not react. So this is the basis for the Bethnicol hypersensitivity test. Though it is not used in clinical practice, it is one test which you should know. And so rise in pressure more than 50. So 100 ml of fluid is put in the bladder via filling, and at that 100 ml, whatever is the detrusor pressure is measured. Now, normally at 100 ml in a normal person, the detrusor pressure should be less than 10 centimeters of water or 0 to 5 or something. But suppose this patient, now we are trying to find out that is this detrusor having a problem or does he have a neurogenic problem? So maybe his bladder pressure may be 15 or 20. So any rise above this by 15 centimeters will label it as a neurogenic problem. And if it doesn't show a rise, or if the rise is less than 15, it is a myogenic problem. So you understood? So you just understand basic things about this test, and as we go ahead, we will tell you more intricacies. So suppose there is an obstruction. Now, whenever there is an obstruction, the detrusor works more and it produces more pressure. So whenever there is a high pressure and low flow, we label it as obstruction. But if there is an obstruction, but the detrusor is weak, like compare it to a horse. Like if there is a very healthy horse and you give him a task of jumping over a fence, and if he's a healthy horse, he will jump at a very high height. So the detrusor pressure will be very high, and that is obstruction. But suppose that it's a very weak horse, he may not be able to jump. He may not be able to produce a pressure. The detrusor is diseased, or it is not. So a diseased detrusor may not be able to produce a high pressure to overcome that resistance, but obstruction can still be there. So, as I told you, if the P dent is normal, that is less than 40 or 50, depending on in a male patient, and there is a normal flow rate of more than 12 ml per second, it is called a normal state. When there is a high P dent and low flow, it is called obstruction. And then we come to the most difficult part of urodynamics, when the P dent is also low and the flow rate is also low, and here is the place where we have to find out the cause. What is happening? Is there obstruction or is there no obstruction? Should we operate or should we not operate? And what should we advise the patient about the outcome? Here, always remember, we have to use the clinical history, what the patient tells you. That will be one more additional feature, or it is rather the most important feature, which will tell you whether what decision we should take about such a patient. Now, because this unfortunately our exam system is the rote type of exam system, where we want you to remember definitions, want you to remember figures, want you to remember names. So just to cover this, I'm telling you the rest of the definitions. But in practice, they actually don't matter to a greater extent, or we do not depend on them to take a decision. But it's important to know, and they're automatically generated in any of this recent software. So what Griffith did was he measured bladder pressure and urine flow rate, and at a given volume of urine. And he measured this, he thought that this is the function of the bladder which can be measured independent of the urine. And so when the bladder pressure rises, the urine flow will not rise till the bladder pressure equals the intrinsic urethral pressure. Only then the flow will start. So this was his principle on which he based this bladder output reaction. And that's why he developed this nomogram. So have you understood what I was trying to say? So at a fixed volume of the bladder, the amount of pressure required by the detrusor to be produced to produce an urine flow rate is what is being measured. And it is an AG number, and it is used for the diagnosis of UPS. It can be used whenever you are in a problem about diagnosis, or whether you are sometimes you are questioned legally as to why you operated and why it did produce the required results. So these are few cases where it is important. So more than 40 is considered obstruction, 20 to 40 is equal, and less than 20 is. And then this comes on each and every graph which we see for uroflowmetry. Now, Schaeffer's line. This is also one of the. So one we saw about the bladder contractility. Now this is another measure of bladder contractility, and this is calculated as, this is known as bladder contractility index, ACI. and it is P dead at Q max, P dead at Q max plus 5 times Q max. Very simple this thing, and you don't have to remember this equation because it automatically comes on your graph. So the normal contractility is 100 to 150. Weak contractility is less than 100 and more than 150 is strong. So I think Dr. Devendra had also so non-invasive urodynamics also utilizes this stop test, and this stop test can be also utilized in invasive urodynamics. That the patient is passing urine, you ask him to stop. If he is able to stop, well and good. If he cannot stop, you can apply a clamp or you can pinch the clamps. Or if he is on a catheter, you can tug the catheter. So here you measure the isometric bladder pressure. And this P-ISO, that is isometric bladder pressure, if it is less than 50, it is the detrusor is under contractile. And if it is more than 50, it is a good detrusor. So this is one more test. So I'm trying to tell you that there are various tests which are devised by various people to try and define detrusor under contractility or under activity. So this is also one more test, that is the stop test. Now, micturition pressure, urethral pressure profile. Now, as UPP, this is also not practiced, but this is also one of the methods of diagnosing detrusor underactivity. So, during voiding, there is a mechanized system in which the catheter is slowly withdrawn and the pressure is measured at each point. Now, usually, when the detrusor contracts, the pressure in the bladder and the pressure in the prostatic urethra has to be same. Only then the flow will start. If both one is high and the other is low, it won't start. When the detrusor pressure and the pressure in the prostatic urethra is same, the flow will start. And then at the level of the membranous urethra, there is a drop in pressure. And this, or even in anterior urethra, and this drop in pressure is usually 20 to 30 centimeters of water. And however, so if there should be the pressure in the bladder, pressure in the prostatic urethra should be same. Once the catheter is withdrawn into membranous or anterior urethra, the pressure should drop by 20 to 30. This is normal. But if the pressure increases by 5 or more, then this can be a method of diagnosing obstruction. So this is one more method which is also not this thing. I won't be talking much on bladder obstruction in females because sir is covering a separate lecture on it. But only urodynamics is not considered as the diagnostic or the gold standard for diagnosing obstruction in females. It has to be supported by clinical evidence, calibration, cystoscopy, or radiology. So this is only one statement I want you to remember out of this slide. Now, just talking about the external sphincter, and that too in very much short time because Dr. Dhawan has already covered it. And as I told you, I just want you to talk. I would just want to talk about the basics. External sphincter will remain relaxed when the patient is voiding. When voiding has stopped, external sphincter will contract. Now, when the opposite occurs, the DSD is always considered to be neurological, though we know that it can be functional, but as per the definition, DSD is considered due to a neurological event, and exactly opposite things happen, that the patient is voiding, but the sphincter is not relaxing, and it is in fact increasing in activity, and this is DSD. Now, there are different types of DSD, but and DSD may be associated with rising P dead, it may be associated with reduced compliance. These are additional things which can happen with DSD, but the diagnosis of DSD is very simple, that the pressures are rising and the detrusor pressures are also rising. So both of them rising is DSD. So usually Functional TSD is a learned behavior in children and adults. It's otherwise usually due to a neurological cause. And here in this situation of video urodynamics will be useful because it will tell you the level at which the obstruction is occurring. Now, this is also one more theoretical equation or theoretical calculation where we try and find out whether the detrusor is acting properly or it is not, it is the detrusor is at fault. And this equation is given in Campbell. I won't waste my time on it. We do not use it in regular practice. So what do you want to remember is bladder outlet obstruction there is equal to storage and obstruction. Detrusor overactivity and detrusor underactivity both are a spectrum of bladder outlet obstruction. So bladder outlet obstruction doesn't only come with high detrusor pressure, low flow. No, it is or it may not be associated with overactivity and detrusor underactivity. Both these things can happen in the presence of obstruction. And there are, even Dr. Shivam was yesterday mentioning that now lots of studies are coming and they are saying that relief of obstruction in such cases may be associated with relief of this overactivity and underactivity in up to 68% or 80% of patients. So this is one more important thing. We always were taught as students that if a patient who is having an underactive detrusor comes to you with obstruction, you tell him that there is a 50% chance that you will pass urine after the surgery or 50% chance that no, you may have to go on CSIC or suprapubic. But now the figures reported in recent literatures are even going up to the tune of 80%. And Dr. sir will also discuss this more with you. So this is one important thing which you need to remember. So the main issue for us as clinicians is to diagnose whether there is obstruction in a patient who has DU. So as I told you that we use Abraham-Griffith number, we can use the Shepard's law, we can use the stop test, and all these things I just explained to you, but I'm just going again over them. These are all other methods which we can supplement and come to a diagnosis as to whether we need to operate this patient or not. So I had one more presentation on the graph. I'll take it in the end during our case discussion. So I request Dr. Yandle, sir.
Yeah, thank you. Thank you, Dr. Sujata. I think we would have Dr. Yandle's presentation and then your presentation, and then we might have a lunch break, and then followed by the live demonstration. So that's the, we have no tea break as such. We have tried to arrange the tea here only in the hall, so you will get your tea. So don't, thank you. Thank you. So I think you just have to interact, and don't make it kind of so that you don't let yourself sleep, all right, during this whole presentation. Try to interact and कुछ सुनाऊं क्या मैं आप लोगों को थोड़ा जगाने के लिए, है ना, सुना देता हूँ, है ना। तो देखो ऐसा है कि आदमी नशे में क्या नहीं करता है ना, तो सोचो कि समंदर सारे शराब होते तो सोचो कितना बवाल, क्या समंदर सारे शराब होते तो सोचो कितना बवाल होता, और ख्वाब सारे हकीकत होते तो सोचो कितना बवाल। किसी के दिल में क्या छुपा है ये तो खुदा ही जानता, किसी के दिल में क्या छुपा है ये तो खुदा ही जानता है, और यदि दिल अगर बेनकाब होते तो सोचो कितना बवाल। दिल अगर, थैंक यू। Thank you, Shivam, sir. Thank you for making the atmosphere light. After that, one share after I share that, what a chart. Let there be no confusion in our understanding. We have been hearing about overactivity, underactivity. I just want to make a clarification to everybody. See, retrograde overactivity to the term is used to describe. Can I have your attention, please?
Keep silent. Please keep silent. Thank you.
So the trigger overactivity is a term used to describe purely the storage function of the bladder, or storage phase of your bladder. That's the trigger overactivity. Whereas diffuser underactivity is a term used to describe features of only the voiding function of the bladder or the voiding phase of your bladder. And therefore, you can get a situation where there is neither overactive nor underactive, or you can get either overactive bladder in the filling phase and underactive bladder in the voiding phase. That's occurring in very neurological conditions. Or you may get one, you may get just underactive bladder, and you may get a normal filling phase. You may get a normal voiding phase, but an overactive bladder. Underactive bladder. So please remember that diffuser underactivity does not exclude overactivity, and overactivity does not exclude underactivity. They are not two different terms, two different types of used to describe two different phases of activation, two different phases of urodynamic investigation. But now that we are in urodynamic investigation now, I think I would like to put some questions to the audience here. Not a simple thing. You're all aware, told about previous speakers about measurement of pressures. So we measure intravesical pressure by putting a catheter to the bladder. We measure abdominal pressure by putting a catheter in the rectum. And why do we measure two pressures? Because intravesical pressure usually is there present the summation of diffuser pressure, pressure generated by diffuser contraction, and the abdominal pressure acting over them together. And you want to subtract that component from the intravesical pressure, so that you will know your diffuser pressure. And then whenever you have these lines, and you find that somebody, if you can actually answer these questions quickly, what changes do you expect in the pressure channels? For example, a cough impulse. When your channels are perfectly well positioned, patient coughs. So let me get the answers from you. What will be the change in intravesical pressure? Rise or fall? What will change in rectal pressure? Rise or fall? Any answers? Intravesical pressure? Right. Very good. Rectal pressure? Right. Diffuser pressure? No change. Absolutely right. So, full marks for the audience. Yeah? Full marks for the audience. Absolutely right. Now, question number 2. This is simple. What changes do you expect in a pressure channel? Diffuser contraction. Intravesical pressure? Right. Rectal pressure? No change. Diffuser pressure? Everybody says right? Oh, good. No. Fantastic. That's absolutely right. Intravesical rise. No change in rectal pressure. Now, take just one other situation. Is the rectal contraction. Now, very commonly seen in neurogenic bladder dysfunction, meningomalosal patients, various kinds of spinal cord injuries, in the rectal contraction. Now, what will change you expect in the pressure channel? Intravesical pressure? What happens? Right. Huh? Right. Who says right? Please raise your hands. Rectal contraction. Come on, raise your hand. Yeah, okay. Fine. Rectal? Rise. So rise, rectal. Diffuser pressure? No change. Book it, जी. So the answer is, I mean, the audience feels the intravesical will rise, the rectal will rise, there is no change. Let's see what the answer says. Wow, something quite different. Intravesical, no change. However, it's catheter in the bladder pressure is not affected because retrousal is not contracting, abdominal pressure is not changed. And remember, rectal pressure measures abdominal pressure. The rectal contraction will not measure abdominal pressure. Okay, rectal contractions are pure rectal contraction. That will not change.
Very important. We have to understand.
So, do you agree with me? The intravesical pressure will not rise, and the rectal pressure will rise because there is a contraction. Now, remember, the computer is there to do prompt electronic subtraction of the pressures. So what have to do the pressure? Fall. Why? Because rectal pressure has risen. Now, computer has subtracted rectal pressure from intravesical pressure. So very often, the rectal pressure may show negative, which is not an artifact. It's the correct measurement of pressure, except the phenomenon had changed because rectum is contracting. When the rectum contracts, then rectum will record its pressure. Computer will subtract the rectal rise from intravesical pressure, which was not reason, and it may become negative. So there is a pressure falls. Okay? This is consider one more situation. What change do you expect pressure down? Rectal catheter slips down. You're putting intravesical catheter. Rectal catheter will just slip down on the floor. What will happen to intravesical pressure? What will happen to rectal pressure? Just logic. Intravesical pressure? No change. Perfectly fine. Agree. Rectal pressure? Fall. Okay. Because it now shows negative. It's fallen on the floor. So it will move up 20 centimeters, 30 centimeters, depending on the height of the table. You have zero perfectly right. But now we slip down. What happened? Reduce the pressure? No change? Rise. Why will it rise? Yes, absolutely right. So intravesical pressure, no change. Rectal pressure will fall because of the negative, but because negative is subtracted by the computer, minus will make a plus, and reduce the pressure will show a rise. All right. We've got the artifact. Yes, it's in a way it's an artifact, but it happens because the rectal pressure has gone down. So as long as you understand this basic logic of measurement of pressure, I think you have known half of urodynamics for this point. But this will also help us to interpret properly. When you're looking at the traces and interpreting, you're interpreting in the light of clinical picture. But clinical picture aside, first, more important, first and foremost thing is Dr. Priyadarshini also told you, that correct measurement of pressure is an absolute mainstay of a good urodynamic evaluation. Pressure must be correct, rectal lines will be properly done. If it's a good quality trace is an absolute must, and then comes the interpretation. Right. So first of all, you will get a history right. You just generate urodynamic questions. One thing that I have to emphasize that after taking the patient's history, maybe incontinence, maybe obstruction, maybe something else. What you have to do is after taking the patient's history, you have to generate the questions for which you are looking, for which the answers will look for. You're looking for answers. For example, you want to know the patient has come with a poor flow hesitancy, straining, possibly he has a residue of 150 ml. The obvious question is the bladder outlet obstructed? The second question is, how is the detrusor function? Is the detrusor functioning adequately? These are the questions we have. A woman comes with incontinence. The first question is, what is the mechanism of incontinence? Is it an urgency incontinence because of detrusor contraction? Is it a stress incontinence because of outlet incompetence? Or is it something else? Or is it an overflow incontinence because of obstruction? There could be anything. Or is it the sphincter loss? What else? So that is the question of interference. And then this after, I mean, many of my say are patient with urogenic bladder. The first question was, is this bladder going to be detrimental with upper urinary tracts? That's the question you want to answer. How safe is this bladder? Patients come to us for transplant evaluation. These patients are deep functional bladders, come for transplant evaluation. The first question asked is this bladder going to take the new kidney safely? Will this be a safe bladder to accept a new kidney transplant? That's the first question to answer. Then you say, is the outlet all right? And is there is a function normal? So generating the questions for which you want to seek the answers is a basic part of the urodynamic evaluation. Anyway, one or two more questions. What units do we use for measuring difference of pressure? Millimeters of mercury, millimeters of saline, centimeters of potash. What is it? Yeah. Are you using what, saline or water? You're using saline, but it is a convention to say that we are using water. And the correct answer here is centimeters of water. That is what we say. We always mention the diffuser pressure went up to 25 centimeters of water. Overactivity went up to whatever. Centimeters of water is the question. Right. What usually when you use measuring the urinary flow rate? MS per minute, MS per second, centimeters per second, centimeters per minute. mLs per second. Very simple. mLs per second. Very good. Okay. One more question coming up. Yeah. Right. Rotating disc technology is used in which part of your equipment? Pressure flow technology, sir? Answer is intelligent. Thank you. Congratulations. Very well done. Very well done. Okay. The initial topic given to me was urodynamics in the elderly, and it would quickly cover this. I think the time permits Sujata has asked me to cover one more topic about the okay. There are some special issues in elderly, and those issues are the physiology change of aging in agriculture. For example, it's a decline in the physical function. Many women have void, we do not have a very strong void contraction. There is a relative underactivity in those people. There also reduction in bladder capacity. This has to be understood. And there is increased urinary frequency, which is multifactorial. And always poor bladder emptying, which may not be clinically significant. Associated comorbidities to Parkinson's disease, dementia, and it does produce decrease of overactivity, and it does produce patient symptoms of increased urinary frequency. So there is frequency, urgency, incontinence, and they often have large residual volumes. Now, what is the residual volume? How do you calculate residual volume, and what is significant and insignificant? It's a very difficult, and I think it varies with the patient, it varies with the patient. For instance, the ICS definition of significant residue is 1/3 or 30% of the functional bladder capacity. And how do you measure functional bladder capacity? You do bladder diary and just find out what is her maximum water volume at any given time. For example, she may pass 125, 175, 250, 275, 150, 175, and so on. But 275 was her maximum volume voided in the diary. So 275 is called maximum voided volume, or what used to be called functional bladder capacity. So anything more than 100 mLs, 1/3 of 275 will be taken as a high residue. In men, of course, things change, they differ, and then they have to be taken. But I follow a very simple principle is what is the accepted residual volume in a man? It is as many mLs as your age in years. For example, if you're 80-year-old man, you're trying to see a residual volume of 75 is acceptable. Okay, but in a child of 8 years,
even threshold volume of 12 ml could be more significant. This is what I generally follow. I think it works, particular works well. Anyway, coming back to randomly women, is a propensity, the friendness is also important, and the propensity to develop urinary infection as urinary retention. Okay. This is the principle. Indications must be followed to be carefully chalked out. They are basically all these symptoms. Stress really important, void difficulty, suspicion of perfection. One thing I want to emphasize here that in an elderly frail woman, why do you want to subject her to enhancing neurodynamics? If you can manage it a simple matter. Obviously, right, you can manage simple matter. But mind you, because their symptoms have mixed and there are a lot of overlay of various other comorbidities, I think it is important to actually distinguish one from the other, and therefore it's very important that we should have careful urodynamic evaluation to find out the precise cause of the symptoms. Okay, these are just general USI guidelines saying that you should do. Obviously, you all know that overactive bladder, we treat them with physical measures like bladder training, the pelvic floor muscle training. They use the drugs, all right? And if they're refractory to those diseases, then you have to consider invasive options of botulinum toxin, neuromodulation, augmentation system class. But when it becomes a stage of refractory, so they have the similar symptoms, not altered significantly, confirmed by the other diary, then we should consider neuroanalysis in those patients. So they are not different. Anyway, I will not go into this now, but let me give you some examples. Special issues as I talked about, justification of urodynamics prior to surgery is high incidence due to the overactivity. Big symptoms very common. Incidence of KDO. Anybody knows what is CADO? Cough associated decrease of overactivity. Very common in elderly women. There is a dysfunction, there is body deficiency, and not good counseling. This is my orientation. Blue line is for bladder, red line is for rectum, green for retriever, which is a flow. So my orientation would be this is intravesical pressure, this is abdominal pressure, that's the basal pressure. And that's how a normal recording of a female should look. Look at the quality, this is very important. There is a rise in the diffuser pressure of the intravesical pressure, equal rise rectal pressure, practically no rise in diffuser pressure. And when it comes to voiding, before voiding, you check up that pressures are right, and after voiding, also consider that pressures are right. So that's you need to have a quality of this. What anybody can tell me what this shows? This is a storage case. This is the storage phase. Intravesical pressure, diffuser pressure. What does it show?
Overactivity.
Diffuser, overactivity. This is the pressure and the overactivity. Actually, right? This is the overactivity, and this is the continuous. So that's what it is. This is a slightly different patient of stress urinary incontinence. And what happens here is she is asked to cough. The cough impulses are measured correctly. There is no rise in the diffuser pressure. But immediately after cough, what has happened is the diffuser has gone into contraction. See that? And that is leakage. And this is stress induced. This is the overactivity, and this is also called KDO, associated with the overactivity. So the advantage of knowing this is the woman complains that she leaks some coughing. All right, so a clinical picture is of stress incontinence. So what we actually find out here is she does leak on coughing, but her leakage is associated with diffuser contraction, not with cough. The coughing is not associated with incontinence, but after coughing, the triggers of a detrusor contraction, and that is produced leakage. So this patient will require, yeah, the pharmacological treatment and other physical measures for getting the overactivity rather than surgery for stress incontinence. This is what we need to know. Again, to find out the quality of traces, good thing, it has to cough, there is a leakage there, fairly good, of transmitted well, good transmission, good subtraction here, all right, and then, and this is the, so this is a case of pure stress urinary incontinence, and that's the word. You may account for the low pressure they void, and this is something I also want to come back to. Yeah, look at this. Yeah. Do you know that? This is a filling phase, storage phase. No rise in pressure, perfectly fine. She happens to have poor sensation. That doesn't matter. She has a very large capacity. But what has happened during voiding? There is no demonstrable rise in pressure. But voiding has a problem. What would you call it?
It's word flu.
Yeah, can you label this? Anybody?
Word flu included here, artifact.
I'll give you choices. That is the underactivity, urinary incontinence, normal bladder. Normal bladder? Who said normal bladder? Hey, come on, raise your hand, please. Oh, good. Why do you say normal bladder? Sorry? I can't hear you. Did I say it loudly?
Yeah.
I have problems with breathing also.
Please. Bladder is prostate and
What do you say?
In women, sometimes voiding can occur by a single just pelvic floor relaxation.
Yeah, but why do you want to make a conclusion here that bladder is normal?
Is there a rise in intra-abdominal pressure by straining? No. No. It's voiding without straining. Read the artifact.
Your answer is perfect. Listen, your answer is correct. Bladder is normal. I know why I say bladder is normal, because she is producer. Normal flow rate, that's very important. Okay, if you want to diagnose it is an underactivity, this is of the normal flow rate. Yeah. I don't know if I can do that. Show you here. Yeah, okay. This is something or underactivity. Yeah. All right. What's important here is that she has whatever bladder pressure she has produced, it has produced a normal flow rate. Okay. Now, the second question is, why is bladder not contracting? Is she voiding only by relaxing the pelvic floor? Or is she voiding by contraction which is not by order?
So the transducer may have come out, or it may be an artifact.
Maybe.
The transducer may have come out while voiding.
No, it is there. It is there. Nothing wrong with the transducer.
You can say, I mean, patient asked you why, I mean, you cough.
So it's not.
So you can confirm that your recording is perfect. You can say, cough before the voiding, cough after the voiding. You have done both perfect. Here also. Okay? So they are perfect. See, remember, yeah,
In females, we don't have like prostate or any outlet resistance, so there might be no recording on transducer contractions.
brilliant answer. Please sit down. Brilliant answer. See, what is detrusor pressure? Detrusor pressure is not purely a detrusor contraction. Detrusor pressure is a response to two things. This is not something I need you to understand. Which is the pressure generated in the bladder is a response to of two things. Number one is force of detrusor contraction and also the outlet resistance. See, if the outlet resistance is high, this bladder is going to generate a much higher pressure. The force of contraction will be the same. But for that same force of contraction, if you just relax the urethra and don't give any resistance, then the same force of contraction will produce a flow, but the bladder will not be allowed to register a pressure. You see? Therefore, what I am trying to tell you is try to understand this phenomenon. The detrusor pressure is simply a response as a result of detrusor contraction and outlet resistance together. They must become together. Now, if in spite of this, with this detrusor pressure, she had a very low flow, then I would have said, yes, this is detrusor underactivity. That means she's not able to, had she produced a slightly higher contraction, she would have produced a better flow. So, detrusor pressure is a response. Is a response of force of detrusor contraction and outlet resistance. That is the reason we say that outlet obstruction is characterized by high pressure and low flow. Why? Because the detrusor is contracting normally, but the resistance it encounters is so high that the high pressure is generated into the bladder. It does not necessarily mean that bladder is strong. No, it doesn't mean that. I mean, maybe, but it doesn't mean that. Okay, so high pressure only is, but for that high pressure generate detrusor will be normally contracted. If the detrusor is weak, then it may not be able to produce that high pressure. That is also sure. Okay, but remember the outlet resistance must be taken into account every time you take a pressure flow into confidence into consideration. Okay, few things document detrusor overactivity, symptomatic pain. And this is another thing. If there is not much of detrusor contraction, there is no flow. Should I ask the word? So this we could label as detrusor underactivity. Okay. So now I want to give you some example. Fine. Now, yeah, this is actually showing you to show you that some detrusor overactivity.
She hasn't voided.
Yeah, well, she had overactivity.
Overact, but she hasn't voided. So
yeah, she hasn't voided. She hasn't voided. No, there is no voided. But that's okay. The object must show you overactivity. And what I want to say is asymptomatic detrusor overactivity is does not contraindicate surgery and may help counseling the patient better. Obviously, when we have asymptomatic overactivity, it has no meaning at all. It's because of dementia, aging, mild cerebral degenerative problems, so they can happen. And then we can give it overactivity, elderly. But that doesn't mean much. If they don't have symptoms associated with overactivity, then it can be ignored. So what I'm trying to say, if the patient is stress intolerance has detrusor overactivity, it should not contraindicate the surgery for stress intolerance. So overactivity is not a contraindication, provided it is symptomatic. But it's better to know, register that overactivity was present, because this woman, after surgery, may develop symptoms of overactivity, and she may blame you for giving her those symptoms by your operation. But now you have a defense. She had overactivity before surgery. You have not given her anything more. This is just an justification of doing urodynamics beforehand. Okay. Now this is a patient of mixed incontinence. She has overactivity, incontinence, and she also has leakage and coughing. So this is a very common situation in elderly women you find that they have incontinence which are multifactorial. And how do you treat these patients? You need to find out which is the more predominant element. And here you obviously find she looks very little on coughing, but she has more leakage associated with overactivity. And therefore that will take precedence in her match. But obviously, and then that is how we treat it. And she's much better off if you treat with antimuscarinic physical measures.
in this particular graph, how do you say this is not a cuff associated detrusor overactivity? This could be the cuff associated detrusor.
Yeah, this could also be cuff.
Yes, so the cuff,
yes,
neither it has.
This one could be. And
even the dimple also.
Yeah, this one could be. Yeah. Absolutely. Thank you. Thank you. So, define which company more predominant as well treatment accordingly. All right. Again, what is this? Now you can see this is good flow, good pressure. So this is a good bladder, and it also has a very good outlet resistance to produce that pressure. this is also tells you that outlet is not bad. Outlet is pretty good. Okay? Because if she generated the pressure, contraction is still there. Yeah, really serious to believe that women void by relaxing the pelvic floor, which I'm sure you agree is not true, because pressure generated depends on number of other factors. Okay. Now, this I don't mind showing this slide. Yeah, mixed importance. So again, the same thing. She has leakage here. Yeah. Important thing is the quality of tests. You must always make sure that the quality is good. How do you know that? The subtraction happens good before the voiding and subtraction again confirms good cases after voiding. So whatever is recording between must be valid here as well, the same thing. Subtraction must be good all the time.
In case of asymptomatic servo,
Yeah,
we have to see the EMG activity also at the same time.
you have to see what?
EMG activity also.
Uh,
That has not suppressed the.
See, if you do EMG, EMG matches in the non-neurogenic case, normal innervation. You should expect a reflex relaxation of the pelvic floor and the external sphincter, okay, in response to the contraction. So EMG may show relaxation. It does. Sometimes actually, it does show relaxation. No. Okay.
Along with
This is
that,
good EMG recording. See that?
no, I'm not talking of this case.
That's
I'm not-
here. And also during voluntary voiding to relax the pelvic floor.
No, I'm not talking of this case.
Huh.
Asymptomatic diffuser overactivity.
Huh.
You said that surgery can be done.
You have what?
Surgery can be done in those cases.
Yeah.
But if along with diffuser overactivity,
Huh.
if we find increased EMG activity,
Uh-huh. Okay. So
so that diffuser contraction, patient is trying to suppress incontinence.
correct. Absolutely.
So that's not normal.
That's right. That's right. That
But
happens.
we have to see the EMG activity also at that time
Yeah.
to see that the patient is not suppressing that contraction to
Correct.
prevent
Yeah.
incontinence.
Correct.
So label this as
Yeah.
normal.
Correct. But remember, patient is not having symptoms of urgency at that time. Asymptomatic is asymptomatic. She has no urgency, so she has no desire to contract the pelvic floor at that time. That also is true.
Yeah.
This is the question.
This will be always associated with the urgency. So now then it becomes symptomatic. It is not
Yeah.
no more asymptomatic. So this contraction of EMG will always be
Just
associated.
not given the history, but looking at the graph, if
No, during urodynamic study, only the patient will complain of urgency. So during UDS also, you have to be aware of what the patient.
And this is to show that the leakage can occur because of overactivity and sphincter activity EMG responded that. To be absolutely honest, surface electrodes cannot be level of mind. So I really inject all my cases, but I really don't rely on EMG recording every time. Because something that you're not supporting, some wetness,
EMG activity is always one. It's not always full. There is some assumptions.
and we are not measuring the electrophysiological recordings of the external sphincter there. We are only measuring the average bioelectrical activity of the pelvic floor. By measuring even the whole age. Yeah. Unless you took a middle electrode into the sphincter on the ultrasound, which we don't do. So anyway, mixed incontinence,
Keep silent.
Okay, no, that. Origin incontinence, cup facility overactivity. That's another feature we can make out easily. She has got, these are very common problems in elderly. She has stress incontinence because she lives on a very low cough impulses. Low in the sense 30, 40, 50. So, but at that low pressure she needs, she has a very severe incontinence, probably an IST. Okay, probably intravenous deficiency. And now what happens here is she voids, there is not much of a demonstrable pressure rise, and there is the flow is very low, but there is a lot of straining. Yeah, very commonly seen in elderly women. So now she has, in addition to all her problems, she has probably got an extensive peripheral autonomic neuropathy, which has led to the symptom loss and also led to diffuser dysfunction, and she's avoiding entirely by straining. Now, these patients have to be taken very carefully. If you give them a sling, they might go into retention. If you are too tight, the retention. Too loose, there will be leakage. So we have to be very careful as to how to do that. I think I don't know the best way to do that, but provided you give them a sling, controlling confidence, and put them on intrathecal catheterization by prior consultation. That's what
Yes, one question.
Yes.
One question is pressing. She has got intravascular rise in intravascular pressure. At the same time, EMG activities are there. Okay, that is the pressure. I'm talking about abdominal pressure. There is rise in abdominal pressure in this stressing. At the same time, EMG activity is also high. So probably she might be trying to squeeze her abdominal muscles and gluteal muscles to prevent leak. That might be the possibility for.
Yeah, she can ask to avoid it. Yeah, this permission is given to body.
Okay, I will
This is the body.
Oh, this is okay. So
I mean, you must understand it. The body phases, patients are asked to see the images is a very high that because of strain. Huh?
Now there is the increased activity in the EMG while voiding.
Why?
While voiding, there is an increased EMG activity.
Correct.
So
Because EMG is not specific of strain type. EMG is specific of straining. So straining is high EMG. That's the problem about EMG. But it's a correct recording. So no question about that. Recording is perfect. That's the scientific advice. But EMG records because of she's straining to void. So even if she coughs, she will show high EMG recording levels. So that's the problem. The problem is that this is pelvic floor also contracts with the strain. So physical contraction pelvic floor, which EMG has the most of it, which is right. No, I mean, see, she must relax her pelvic floor to void. I agree. But when she cannot void it because of a poor diffuser, she uses external abdominal muscles to extend the urine. That is the phenomenon. And that's correctly recorded. With a short rectal rise, pressure rise here, subtracted well, no diffuser contraction, there is a flow because of straining, and because of straining, there will be a rise. So it's all perfect. I mean, it demonstrates the phenomenon.
So difference in difference another question we are discussing is DSP. DSP, we don't see rise in abdominal pressure. So it's just diffuser pressure which is rising at the same time EMG activity is rising. Not like that. Yeah.
That's right. You see in neurologically abnormal patients. So the entire mutation reflex is disrupted. And therefore, what we usually see in say infrapontine suprasaccharine where once has lost its control over the coordination between bladder and skin. And therefore, whenever diffuser contract, sphincter tends to contract. And there are various ways in which one. So what CCU really is abdominal pressure rises immensely, no flow takes place. All right. And suddenly the diffuser pressure falls and the flow takes place. So pressure high, low flow, pressure low, high flow. This is what happens in DST. But that's again logical, isn't it?
everyone should got it right. Anybody has any confusion, you can just ask, right?
I want to ask a question.
Yes.
Sir mentioned, even I mentioned TSD is always related to neurological problem, suprasacral usually. So what carefulness or what things should come to your mind when you're doing any systometry in such patients? What can happen? Locally, autonomic. So which drug do you take? Huh? Always keep that in mind. So the corollary answer.
Also, you have to deflate the bladder. Your bladder is getting full, deflate the bladder. And then put, yeah. So what is the dysreflexia? I think everybody knows. So anybody would like to say what is autonomic dysreflexia? Lesions above T10. So what happens? What happens medically? The symptom could be of tachycardia, hypertension.
So I almost finished up with this. Is okay, since you understood. So in DSD, it's for discerning, it's a different phenomenon. And the pressure rises because diffuser is contracting against the closed sphincter. And as we discussed earlier, the pressure depends on the outlet. Outlet is closed, bladder is contracting. That's why the pressure goes on. But the moment sphincter relaxes, which it does very often, suddenly the closed urine starts gushing out, and that is why the pressure drops. Because now bladder has not much of resistance to contract against. So the pressure falls. So pressure falls, flow takes place, pressure rises, and flow stops, pressure rises, and that is how it starts in DSD. But there are various types of DSD, but this is the basic fundamental of understanding helping system. Dystonia, see classically in suprasacral spinal cord. When I say suprasacral, I mean the neurological sacral center is in T12L1, right? Sacral cord, T12L1. If any fracture above L1 or L1 above L1, up to the level of the cervical spine, we produce suprasacral cord lesion, and DSD is a very, very common statement in those cases. But if it is suprapontine, such as it is a cerebrovascular accident or head injury, then the pons is capable of a coordination between sphincter and the bladder, and therefore you don't see DSD in suprapontine lesions. The patient with stroke, very common, has got frequency, urgency, incontinence, but does not have a DSD. Dementia will not produce DSD. But response is intact, and pons to sacral cord is the connection is intact. Therefore, elevation and coordination is perfectly well organized. Anyway, so I just finished with this presentation now. Just to say that severe degree ISD, intestinal deficiency, is very common in elderly women, and therefore it becomes a problem in marriage. Okay, and that's a kind of problem. Severe underactivity associated with severe. So, what is the special problems about elderly women? Reduced underactivity is extremely common and can complicate the diagnosis of obstruction, but which is not a point here. Reduced overactivity is common and is multifactorial, can be asymptomatic, and often asymptomatic. Urinary incontinence is the most challenging diagnosis because you need to really understand, do urodynamics very carefully, talk to the patient continuously while doing urodynamics interactively, which you'll see in the video. And that is how you can dissociate all this phenomena one from the other and make a precise diagnosis of incontinence in the video. This is a urodynamic laboratory, which is one photo that I normally show. And thank you so much.
Thank you. Thank you. I think we will, if we have time, we will take the next kind of presentation. Now we will invite Dr. Mani for his talk on pediatric urodynamics.
So, Dr. Mani, please. So I would like you to, we will have some kind of feedback from you also regarding this whole aerodynamics course. So please give us the feedback about what did you like most and what did you didn't like. So let us know so that we are more aware of this our data.
Good afternoon, everyone. I'll be speaking on aerodynamics. Technically speaking, pediatric aerodynamics is almost same as that in adults, but there are certain differences. And there are many specialized applications of aerodynamics in children, unlike in adults. Pediatric aerodynamics is not easy to do because a small child uncooperative doesn't understand, he doesn't obey the commands. Parents are apprehensive and confused, and it really tests your patience. Now, pediatric aerodynamic study is a group of tests done for the assessment how well the child's bladder is functioning. Objective of aerodynamic assessment in children is to reproduce its symptoms or the three different situations with aerodynamic study in one is specific neurological disorder affecting the vestibular function. Non-neurological disorder affecting vestibular function. IUTS suggesting a vestibular dysfunction with no underlying disorder. Pediatric UTS is classified into two groups, simple or non-invasive and invasive. Full evaluation involves both. Full evaluation, that is non-invasive plus invasive, define the pressure volume relationship within the bladder in order to ascertain at what pressure does the bladder store urea, that is compliance. If there is any abnormal dynamics, overactivity, or poor compliance that may harm the upper tract. And thirdly, empty efficiency of the bladder, reduces contraction and sphincter function. In addition, video aerodynamics play a very important role in pediatric aerodynamics. Video aerodynamics provides additional information that may contribute to a further understanding of the problem under investigation. Features that may become evident include structural abnormalities, diverticulae, residual valve, strictures, etc. Viewer, whether it is present during filling, voiding, or both. Functional problems like BSD, bladder emptying, true and false residuals. Now there are more specialist application of UTS in children. Two most important are posterior retinal valves and VUR. In both these conditions, UDS helps to understand the evolving natural history of lower urinary tract in both these conditions. The third, spina bifida. Fourth, pediatric UDS is useful to test the efficacy of treatment as well as to determine any refinement necessary to improve the outcome of such treatment. For example, evaluating the success of procedures to improve outlet resistance in extrophic bladder, Kelly's repair. Number 5, assessing the effect of botulinum toxin injection in neuropathic bladder overactivity, and also assessing the impact of correction of reflux with bulking agents in early life on long-term outcome of bladder function. Now, if you come to simple and non-invasive UDS, it should be performed in all children referred for evaluation. After initial assessment with non-invasive UDS, some children will go to have invasive UDS. 3 components of non-invasive UDS: frequency and volume diary, interview, and bladder function assessment. Now we come one by one. Frequency or volume diary. Frequency or volume diary possible only in toilet-trained child. Diary will document the periodicity and bladder volume during the day, which will reflect the functional bladder capacity. First void in the morning after a dry night will reflect the maximum bladder capacity. It also helps to act as a positive feedback tool and yardstick to assess the efficacy of treatment. And findings of non-invasive urodynamics is compared with the findings of invasive UDS to reach a logical conclusion. Second is interview. It helps to evaluate the child's nature, his attitude to the problem being assessed. It gives information regarding his home and school environment and assesses child's compliance for the introduction. Now, by using non-invasive UDS, how we assess the bladder function? 2 free voids into uroplometry. Watch for abdominal effort during voiding. Measure residual urine in each one. All these points, after that, we need to find out whether invasive UDS is required or not. Now, invasive UDS. Invasive UDS is difficult to do or interpret, especially in an uncooperative child. In order to obtain reliable and reproducible results, it is important to ensure team of specialists, nurse, radiologists, and urologists, familiarization of the child, and parents with the team and environment of the urodynamic suite to provide precise information regarding the test, discuss possible complications with parents, and explain the limitation of the test to the parents. Now, types of non-invasive UDS. Natural filling UDS, standard filling artificial CMG, video contrast filling CMG, isotope filling CMG. 1, 2, 3 are usually used. Technique. Similar to that in adults, most centers use urethral catheter. Single or double lumen suprapubic catheter, if placed 1 day before under anesthesia, appears to be the best option. Most centers report similar findings whether urethral catheter is used or suprapubic catheter is used. Suprapubic catheter is inserted 24 hours prior under anesthesia. It gives the best possible environment for study. Now, disadvantage of urethral catheter. How small may be the catheter? It will contribute additional resistance to the outflow. Error in estimating true outlet resistance, and usually we overestimate. Catheter normal induction sensation results in taking interpretation of the
छोटे थे किन काउंट
already
पे
bladder diameter.
फीवर आ नहीं रहा हाँ हाँ
Now come one by one to the natural filling uterus. Natural filling uterus is suited for infancy or early childhood. Single lumen catheter for second, rectal catheter for abdominal pressure. 3 filling and voiding cycles are required to establish reproducibility. Advantages of natural fill uterus. Slow rate of filling minimizes risk of iatrogenic recusal overactivity. Small caliber tube is sufficient, minimizing risk of bladder spasm, and it is more physiological. Disadvantages of natural fill uterus. Take long time with large bladder and upper tract storage. Synchronous fluoroscopic imaging not possible. Thus, information regarding BUR, there's residual obstruction after UV perforation, it cannot be ascertained. Artificial fill uterus. Ideally, bladder is usually filled with the aid of gravity at a rate not more than 10 to 15 ml per minute. Advantages of artificial fill uterus is time required is short. Synchronous fluoroscopic imaging is possible. Disadvantages of artificial fill uterus. Instilled fluid temperature is less than body temperature. It may induce recusal overactivity. A high rate of filling can result in recusal overactivity and reduced bladder compliance. Presence of larger catheter may induce bladder spasm. Requires child who is cooperative and able to respond to instruction. Now, special application of UTS in children. As you know, a boy with posterior urinary valve will have normal bladder function, but many of them develop valve bladder syndrome and damage to the upper tract. Indications of invasive UTS in cases of posterior valve. Persistent daytime incontinence after age of 5. Deterioration in renal function with no obvious closed part. Increase in upper tract dilatation in the absence of outflow obstruction. Prior to renal transplant to ensure compliant pressure with renal tract. And if not invasive UTS is required after during circulation, it is better to wait for 6 to 12 months. Next, a specialist application of UTS in children is BUR. Up to 50% of children with BUR may have associated voiding dysfunction. Urodynamic evaluation may play a role in the management of BUR by identifying those with bladder dysfunction. Video UTS is the study of choice. Slow rate of filling with frequent fluoroscopic screening helps to determine the severity of the problem. You are in early stages of bladder filling, that is low pressure reflux. In each case, the pressure recorded will reflect system, bladder plus upper tract, compliance and capacity. Viewer during the end of bladder filling or early during voiding is called high pressure reflux, and in such cases, viewer has no effect on the bladder storage characteristics. An incomplete bladder emptying may be due to underactive bladder or hyperactive, hypotonic bladder, or refilling from the upper tracts. Now, one important specialized application of UTS in children is spina bifida urodynamic bladder. Urodynamic bladder dysfunction due to spina bifida is a major source of urologic abnormality, especially in those with spina bifida. Children with spina bifida and urodynamic bladder are at risk for chronic kidney disease, recurrent UTI, and urinary incontinence. Two types of management for spina bifida. One is proactive management approach, another is expected management approach. In proactive management involve early invasive EDS to detect high excessive pressure and interfere before renal function starts deteriorating. An expected management approach involves surveillance laboratory ultrasound imaging without invasive EDS, an approach which is safe. Literature suggests proactive management has got a better outcome in preventing the other side. Thank you.